Here we go. So it's 11 a.m. Welcome, everybody. It's Friday, July 18th, and we welcome you to the Florida EMS webinar. We do these every Friday at 11 a.m. We now are streaming live on LinkedIn, where, by the way, we get thousands of views on the LinkedIn views. And then on YouTube also, we have hundreds of these talks. And if I always tell people, if you want to know where to change your protocols, where to find leadership topics, you come here to the Florida EMS webinar. And we've been very privileged to be joined by just truly amazing people in our field. And today is no different. How did this come about is many of us have had to deal with holding the wall time, APOT, whatever you term it, we all deal with it. And when you look at the issue, they just kind of look at EMS and say, you stand there and then we'll just fix what we have to fix. But what they're trying to fix is not the right thing. So I came across a commentary in a journal, and I saw them on social media, and I reached out immediately, and they right back said, we're in. So today we are very privileged to have three amazing presenters, and you can see them here on the screen. They have very, very big roles. They're running very big systems. And we're just very privileged to have Dr. Barkoudah, Dr. Gemme, and then Nate Stanaway. And they all know each other. They've worked together in different aspects. And I would love for them to, I'll start with Dr. Barkoudah. If you can begin, pass it over to Nate, introduce yourselves. Thank you so much for joining, and then take it away.
Such a point of privilege having us. So we are grateful to you and for the audience and anyone will watch us. Ebrahim Barkoudah, I'm Assistant Chief of Hospital Medicine at Baystate Health in Springfield, Massachusetts. We are an integrated academic system. We have 4 hospitals. We're affiliated with UMass. I live in a different bubble called the inpatient services. And I came to this work through Dr. Gemme and Nate. And I have a little bit different starting point, but eventually we're all marching toward the same finish line. So I'm going to keep the suspense there and turn it to Nate.
Hi, good morning, everyone. Thanks for joining. Nathan Stanaway. I'm the Director of Transport and Logistics at Emory Healthcare. As our colleague mentioned, EMS is a small world, worked with a lot of the same folks at the Massachusetts Baystate Health location. Throughout COVID, tackled lots of challenges during COVID, as I think we all did, which really highlighted the opportunity for avoiding holding the wall. So my background is as a paramedic, so I'm happy to bring that perspective to this conversation, and I look forward to and talking more.
Thank you both.
Dr. Gemme will join us, and he will dock where the exact entree for the talk. So let me maybe start, Peter, and first of all, we're grateful for this, and the more and more learning how we can run hospital from the door, from the ED, from the EMS, all the way to discharge is a continuum. I'm going to start with the piece that you shared, in which I started my role, started working closely with Dr. Gemme and Nate and the EMS. And I'm going to share with you my vulnerable part. I never heard the term holding the wall. And it struck me when I knew that there were 5 EMS holding the wall. And that is the urgency of what we need to do when we manage healthcare. So I went back to my office, drafted the first draft, sent it to Dr. Gemme, went back and forth. This is our piece, happy to share it with you. It got accepted without a revision. This is how we see healthcare today, and likely tomorrow, in terms of ED crowding, in terms of the patients we need to attend to their care throughout this continuum, is not going to change. We do operate in an academic setting. I don't want to start my talk as a researcher. I want to get you to the ground level of how we manage it and then pull it back all the way so we can all have this conversation. The premise for the work is what Peter been thinking about probably for 2 decades, that the ED crowding is a surrogate of access to care, is not the problem. And I will go through it and convince you that we do have a framework that we can work on it together. I'm going to turn it to Nate, and he would tell you a little bit about the EMS, which you all know about. But I would like to bring it back as a conversation of that continuum of care. Nate, anything while we're building the suspense for the audience?
Yeah. So, Baystate Medical Center is extremely busy. We'll go over a couple more details a bit later, but 150 maximum ambulances a day. Very, very busy. It's not what you really think of. And ironically, it's really because it's kind of, I don't want to say the only show in town, but kind of the only show in town when it comes to tertiary and some quaternary care services. So with that, it becomes very important to have a really tight process for EMS to get into the emergency department, have the patients start receiving care, and then begin progressing through their care. So, and again, as a paramedic, it's always frustrating to have be stuck on the wall, so to speak, with a patient that not only is not getting the care they need, but also you're hearing calls going out in the field requesting EMS services as well. We can go to the next slide and just kind of let me know, when Dr. Gemme joins. But you can see there the Baystate Medical Center Emergency Department, relatively new for the program there and for the hospital there. The hospital itself, very, very old. And I don't remember when it first started. Dr. Barkoudah, do you remember when it started?
Dr. Gemme is on.
He's on. He has arrived. Awesome. Dr. Gemme, are you on?
Yes, I'm here. Sorry about that.
Awesome. No worries. Take it from here.
All right. So thanks for having us. So yeah, Baystate Medical Center, I don't know what you went over, guys, but level 1 trauma center, big, busy. We see about 85,000 patients on the adult side, another 35,000 on the pediatric side. For pertinent for here, EMS comes in the same door, but we're a large, busy, according to some benchmarking surveys, the highest ESI 1s and 2s we see. So high acuity, high complexity admit rates about 48%, which is off the chart. So that's a little bit about the ED. Dr. Barkoudah, you can talk about the hospital maybe.
Perfect. So we're in total 4 hospital system. Our main ship, Baystate Medical Center, as in the picture, it's 715 licensed beds. Our ED is the largest in Western Mass. And to top it a little bit more of data, we do closer to 60,000 discharges across our system, 46 from our main hospital. So I'm going to use a little bit more inpatient terms. If you snooze, you lose. The bed, the time really matters. And I'm going to start bringing that inpatient lingo and get it closer to Dr. Gemme and how we start seeing the problem together and solve it. But the goal here is you do have one stop for closer to 1 million patients population. Access is a key. And, that plaque on President Truman's desk, the buck stops here. We are the buck. So the ED will not close doors. And our inpatient, they need to catch up to this. And I'm going to keep going back to the premise where we started. The ED holding, the ED crowding is a surrogate of access to care, is not the problem that we need to focus on. We need to focus on the system as a continuum. So maybe Dr. Gemme and Nate, let me just start tackling a little bit of the bigger goal and start with it. So the way we walked into it, that to work under that premise of multidisciplinary team, it's not just the ED. You need to bring hospital medicine, nursing, the transport logistics, the analytics, and anything in between to build a governance where your ED is part of the continuum, the EMS arrival is part of that solution, and how you can implement a system that would work day and night, every day with the same efficiency. So these are the flavor of how the framework that we worked on, that to manage that patient flow, we need to have a governance in place. It has domains. So we looked at our data. We dug really deep into the why. We started of the why the patient cannot move, where the bottlenecks, and how we could do better in terms of the optimization. And you start from the admission, you end with discharge, and then the emergency medicine aspect would be in the center of how we do it, because you're going to keep getting these patients, and the audience here, they know about it more than me. To top it a little bit more of not just in theory and the academic, I would say, jargon, you need to have a structure and you need to have accountability. And we build a team where we came together with integration of digital help, with buy-in from every level of the leadership, and really think about changing culture. Patient state in the ED is a high risk, is a safety and quality issues. We need to move fast and not break anything. I live in the inpatient more than the ED, even though Dr. Jimmy really gave me that notion to switch to emergency medicine. We admit 35 million admissions a year in the US. About 18 million admissions are the acute medical surgical. So we need to get it right 18 million times every year, day in, day out. And the work would start by building that foundation of clinical efficiency that's safe, and layer over with quality. To give a little bit more of how we worked on it, reduction length of stay is a music to anyone work in healthcare, but you need to step back a little bit and think how the metrics, how you will apply a methodology that would put the patient into that journey from the ED arrival to the discharge. And what we applied our innovation was how we can focus specifically on key areas related to the ED and the discharges, and what are the best ROI to apply. In Massachusetts, we do have a centralized database that run by our Office of the Healthcare under the governor. So we can take more data and analyze it across systems, and you could see our 65 hospitals with how they apply the care through that center of healthcare analytics. What we achieved in a year, and I'm just giving a little bit of numbers without really crowding a lot of slides, is when you start thinking about your expediting discharges, reducing your patient days, and then start capturing the patients coming to ED through a structure measure, through that capacity management, and lowering how many patients in the ED should be always coming in and coming in fast, and then hardwire how the discharges should be structured, you would achieve more stable system than before. We worked first on the inpatient side. The emergency medicine team were building their infrastructure, and then we brought them all together. That the marriage between how you could reduce your walkout, how you can decrease your median boarding hours while you're reducing length of stay. The coefficient or the correlation, I'm going to put a little bit more professor talk on it. If you look at any system, these are the two, they literally dance together. They do tango every day. You reduce your length of stay, you reduce your boarding hours, and then by definition, you can capture more of the patients that unfortunately sometimes they left without being seen. So they're all correlated, but the goal is to create that thread and connect them together. Our success is about how you can bring these domains. We reach statistical significance across the board, but this is not what keeps me up all night. What keeps me up all night is how we can get to the patient faster and deliver quality of care, because the clock ticks not when we put the admission order. That was my mentality when I started practicing medicine 2 decades ago, is when they come to the ED. And this is how you at least manage these two systems, and really how you can sustain the impact. I will turn it back to Dr. Gemme, and then I'll come back and share a little bit more of the data. Seth.
Yeah, thanks, Ebrahim. So as you're getting from Ebrahim, it's like this whole holding the wall phenomenon, and what you guys are seeing in the EMS world is a system problem. And it's not the ED, it's not the, you know, the charge nurse that you're running into when you break your patient to drop off. It's really, how do we take the patients out of the ED, efficiency and that length of stay in the hospital, as Ebrahim said. And it's also important how we discharge them out of the hospital and how we pull them out. And it's the same EMS units that are bring them in and bring them out, at least a lot within our area. So pertinent to us at Baystate Medical Center, we are #1 according to the Association of Academic Chairs of Emergency Medicine survey on the most EMS arrivals. So this is on the adult side. So this is our adult arrivals from last year, 84,500 about. And we were seeing, you know, this is 125 to 130 ambulances per day. So almost, if you take out our walkouts, more than 50% of our patients we're bringing into the ED are coming in by ambulance. So this created the urgency around all this collaborative work that emergency medicine did with Dr. Barkoudah's team in hospital medicine. And that's what sort of was like, we need to fix this. We need to get rid of the holding the wall phenomenon. It can't just be the ED or the EMS agencies working on this, and it required the collaboration.
Excellent, Seth. Nate, you know, the transport.
Yeah.
As someone who lived on the inpatient side, closer to 47,000 arrivals. I always thought MGH is the place that's crowded. It turns out we're #1.
Yeah, it's you know, it's again, it kind of goes back to the dilution of volume, right? So when you're in a large population center, EMS, we have a lot of options to choose from as far as which hospital we're going to. So, you know, you can kind of pick and choose based on the patient condition and based on your exact location and based on how busy they are. So if Dr. Gemme's ED, you know, had me on the wall for 30, 45 an hour last time, I'm not going back there probably for a few hours at least today. Unless, you know, there's a good EMS room there, and then maybe we'll think about that. But, you know, so if we want to go to the next slide, I think, you know, in my experience, 20 to 30%, and this is held true at the shop I'm at now, which is, you know, Emory Healthcare in Atlanta, which is a 13 hospital system, tertiary and quaternary, massive organ transplant service line, et cetera, et cetera. EMS is required in some form. And when I say EMS, I mean wheelchair vans, stretcher vans, BLS ambulance, ALS, critical care ambulance, even depending on, you know, if they're going to an LTAC or that kind of thing. 20 to 30% of those discharges that you do every day require transport of some sort. So when we talk about the nexus of the bottleneck that results in EMS being asked to hold the wall, so to speak, it truly does come, and I would argue it comes, yes, from the inpatient side, but sometimes it's actually even all the way out to the nursing homes and the post-acute care setting, because we can't get the patient placed. I think we all saw that a lot during COVID, where, you know, you can't get the patient out of the hospital to somewhere that can take them because everybody's full. That backs up all the way, right? It's traffic jam. It's 10 miles of backups because there was a big crash up there. So thinking about it in a holistic and patient flow kind of process map, I think is very helpful. It visually will show your stakeholders the bottlenecks pretty intuitively. So if you've got some folks on your operations excellence team, you've got some people with lean management experience and process engineering, like pull them in to kind of help when you're doing this. One of the things I've found is very important. You can see a little bit of a photo there of our capacity command center, a part of it. That's actually only half of the capacity command center. There's all the other half the other way. But we have our transport providers in the capacity command center with us so that they understand what our needs are as a system and what our priorities are as a system. So if I get a call from the university hospital ICU director, hey, we've got no beds and I've got 3 patients needing ICU beds coming in from outside or coming out of procedure areas, that kind of stuff, we can reallocate transport requests to match actual bed need, not just first come, first serve. Traditionally in the EMS world, it's first come, first serve. That floor didn't call first, so they're not going first. What we do is we have our partners rearrange that transport to match that. So that's going to alleviate and getting some patients out, right? EMS is on the front and the back end of 20 to 30% of the volume, and sometimes more on the ED side, the inbound side. At our shops, it's 15 to 45% is EMS volume, depending on which hospital we're looking at. And so on the back and front end of the patient progression through the health system is EMS. And if you're not collaborating with EMS, you're leaving a lot on the table when it comes to being able to progress that patient through there. So, and then I think another thing is important to tell new EMS providers. Yes, the discharge transport is not glamorous. The interfacility transport may be glamorous, it could be a really sick patient. But the discharge transports aren't glamorous. But when we were at Baystate together, Dr. Gemme, I would come down to the emergency department when I get a call from our transport partner saying, "Hey, I've got a bunch of trucks stuck," and I would say to the emergency department nurse, "Hey, what's going on?" They're like, "Listen, I've got 80 boarders in the ED," and I'm like, "I understand that. Do you want beds upstairs?" "Yes, I want beds upstairs, but I don't have any beds upstairs." "All right." Those EMS providers are going to go get a patient from upstairs and open up a room for you, but they can't because they're sitting here on the wall, and now we have a spiral. So making sure that both sides of the coin are aware of the criticalness of that. Another thing that I think is very helpful is, and we already kind of talked about this, but when you think about programs you can do to collaborate to improve processes, discharge lounges are massive. In our experience there, over the course of a month, reducing the scene time for the patient discharge transport from 45 to 15 minutes resulted in an additional, as far as efficiency goes, two additional ambulances on the road for the whole month, just from reducing the scene times of getting those patients out on the back end. So make sure the patient's ready when EMS shows up, help them help us. Lots to talk about there. I could talk about this stuff all day. I'll leave it there and pass it back to you guys.
Dr. Gemme.
Yeah, thanks, Nate. You can advance the slide. So I just got 2 quick points to make. So as Nate says, data is important, watching the data back and forth. What we did to drive the change here, different from when Nate was here and now, it was developing a dashboard that really shows the intricacies of how our ED is working. So I'm not going to go into every metrics, but if you switch to the next slide by zooming in, go ahead, Ebrahim. So we included right there in the middle the adult EMS patients waiting in bed greater than 30 minutes. So this dashboard is not only in the ED, this was made into a web application that also allowed the CEO, the CMO, the CNOs, all the units on the inpatient units to see this. And this really drove a lot of change. These are the 3 metrics that you see across the top: our waiting room patients, our EMS patients, and our holds that drive our code capacity policy to say, when these hit certain thresholds, the whole hospital starts acting. Patients are moved to dirty beds, inpatient hallway spaces. It facilitates a lot more movement where they don't have to give this formal of a nurse sign off. So putting this here, I think, was a win for our EMS agencies in the area and EMS communities. And, we have significantly reduced not only boarding by 50% in our institution from all these initiatives, but also the holding the wall times are significantly down. So even one patient holding the wall elevates our thresholds, as you see here, 3 to 6 warning greater than. So when they're hit the warning in critical mode, it dings, sounds the alarm, and all those things start moving. Next slide. The other thing here is we save all this data. So that's up, that feeds live near real time every 5 minutes, and I can go back in time. So I picked this particular day. The top metric there is holding the wall. This was a day that was extremely bad. We had periods of time of 6 EMS units holding the wall. And remember, this isn't just sitting there for a few minutes. This is over 30 minutes. And I could go back and say, like, okay, my bed utilization in the ED was certain percentage. My horizontal staffing ratio, so my ratio of nurses was high. So everything was humming here. And our holds actually weren't that bad, but they were bad, right? That we had to change this whole message. They're still in the 40s there. So this picture right here tells the hospital, I got to get out additional holds. And you can see they did slightly improve there, but it needed to be better. And we learn by saving this data and being able to move forward with it. So the last thing, just future exploration, is our last slide. We need to get at more department and unit specific data. I think everyone needs more of that. Like, what are the ambulance turnaround time? Like what Nate was saying, that scene time. Like, what if we had unit specific scene time for ambulance that went always to our neuro unit? Like, maybe there's opportunities there. How do we get at more of our data for around the discharge unit and things? And then other mitigation strategies and alternative methods for caring for our patients in the ED. For those that are maybe holding the wall. So that's what we have for the presentation here, and we can open it for questions. Sorry to be late, and sorry to kind of go over a little bit.
No, that was amazing. Dr. Gemme, we didn't really give you the proper introduction. So if you wouldn't mind just telling everybody what your current role is at Baystate.
Oh, I'm sorry. Yeah, so I'm system chair of emergency medicine here. So I oversee the operations, the academics. We have a 3-year residency program, 48 residents, 10 fellowships, and including an EMS fellowship. And then a pediatric ED, adult ED here at Baystate Medical Center, and then 3 community sites. So it's around 230,000 visits a year that we operate with.
Wow, wow. And I was laughing when you said you guys are #1. I mean, that's a lot of EMS runs to get every single year. So we have a few questions that I know I'm going to bring in Tanner here in a minute. I love the fact that you're not just looking at EMS and saying, oh, EMS is not really waiting that long. What I've seen, and this is a topic I'm very kind of well entrenched in, and I speak to a lot of people around the country, and everyone tells me the same thing, that when EMS says we've been waiting on the wall for a long time as a median, then the hospital retracts back with, oh, no, that's because your medic stayed in the hospital and they went to the bathroom and they refuse to look at what's happening upstairs with discharge lounges, with throughput, length of stay, etc. So this is very important. We do have some hospital administrators on here. I see AJ Ross is on, so thank you for joining. My question is, it's more tactical in nature, but do you see hallway beds upstairs as something that people should be doing? Do you do that today out of curiosity?
So
yes.
We do. Maybe I can start and then pitch it to Dr. Gemme. We do. But Peter, just to build on this, we lived in silo, right? So it's not just the ED, but you need to tell the floor, as Dr. Gemme did. He put the capacity dashboard on every unit, right? So the buy-in is the patients are in the hallway and we have ED hold because we're holding back a lot of patients. And we do all the combinations. So the system should be agile. We work in collaboration. The techs will be flying. The ED and the inpatient, they should be always on the same page. Seth?
Yeah, I mean, our philosophy was that, they're being taken care of in an ED hallway space in the ED. So we didn't do this until maybe a year and a half ago when we started this collaboration. It was really unheard of to put somebody into an inpatient hall. So this is new. So we've changed the culture here, and it was really bred around that. And these patients are going up there usually for like 3 days to sit there in the hall. But what we're doing is if you have ability to improve your efficiency of the turnover of the rooms, and you have a discharge, but we went around and found safe spaces they could go to, and they go up just as if they would be in the ED. But it was a lot of culture change, getting nursing on board. The other important thing in that dashboard is it shows our current ED nurse ratios. And if you show our ratios and publicize that, and we're at 7 or 8 to 1 of undifferentiated patients, and I build in an acuity factor to that, then when they're at 5 to 1 upstairs, it sort of is a more shared collaborative responsibility.
And that's a great answer. I'm going to get to you, Elijah. Let me go to Tanner first, and Elijah, then AJ. So Tanner, just for those who don't know, is a paramedic. He's now a medical student getting his MD, PhD, and he's also written many, many papers. So as my co-host, I bring him in because he's the brains of this operation. So Tanner, go ahead and ask your question.
Yeah, thank you all for this presentation. It's really wonderful. One thing that I really love about your approach to this problem that I think gets missed when this is being discussed a lot is it's often a conversation of like, you need to get us back out on the street so we can take care of the community. It's something the hospital can do for us. Really addressing that, all the ED staff hates the problems with boarding, right? There's tons of literature out there that shows that it's unsafe. It can lead to adverse patient outcomes, worse pain control. I mean, that's been published all over the place. But saying that, as EMS, we're actually a resource to help you guys with that, right? If we're out there decompressing the hospital on the backside. And so I think that's a really wonderful thing, and that's something that should be central to these conversations with hospital systems. In terms of from a research perspective, I think that a lot of journals, including pre-hospital emergency care, are now publishing manuscripts focused on quality improvement. I think this is a wonderful topic, a description of kind of how you've made gains in your system with all the different interventions that you've implemented. I know from a scientific perspective, right? You guys have done so many things at once to address this problem that it might stick in the editor of a scientific manuscript's craw, right? It's hard to differentiate which interventions actually had the biggest influence. But I certainly think that what you've done here, you've shown that it works, and I think that for other hospital systems across the country that are struggling with the same issues, I think that it's worth sharing it so that they can look to you as a model of how to improve their systems. So thanks again.
Thank you, Tanner.
Excellent, Tanner. Let's go to Elijah. And
Thank
AJ,
you.
you're next.
So I saw looks like Chief Zalkin put in the messages. You can change what you measure. That's huge. My question is, how do you get a good measurement of a wall time? I work for one of the hospital systems down in Palm Beach County, and we're lucky enough to have fire rescue sending reports on their time out of service, basically from the time they arrive to the hospital to the time that they go available. But not to say that EMS is sitting around and hanging out talking to nurses and in the EMS lounge eating snacks. We don't think that, but there's also other operational delays like cleaning your unit and doing a debrief and all kinds of other stuff that's very important, and we encourage that. But it's difficult from the hospital side without having somebody to physically lay eyes on them when they walk in until they turn over care and put the patient in a bed. And even that can be hard to measure sometimes. So what are you guys doing to get an accurate measurement of that hold on the wall?
Yeah, I mean, that's a great question. We were designing this and putting it as a metric, we were really considering what to do. I mean, it'd be nice if I had somebody there with a stopwatch, right? And when you actually look at all the disposition metrics that an ED physician might do, door to doc, bed to doc to dispo, you only have surrogates of that time from the EMR. So I care about, the hospital, we don't, I mean, we care about how long it takes to get your truck clean, but that's more on you. But so I take in what I control, what we can measure. And what we do is every EMS unit that comes in, they quickly get registered. There's not that, we have a process where there's not a big gap between the arrival and registration. So they get registered very quickly. So that's a advantage to the way we do it. So once they're registered, they go into a designation where now the stopwatch has started in the computer. Once that hits that 30-minute mark, boom, they flag onto our dashboard. But we still know the ones less than 30, we know it's coming, it's building and things. But we use the initial timer registration, which fortunately for us is short, and then we start the timer from there.
Gotcha. So that's like reg to bed, and if it goes over 30 minutes, That's when it flags for you. Got it. Yeah, we're experimenting with that as well. Yes, I think there's some difficulties anywhere where you have human entry. Sometimes they missed that it was an ambulance that was brought in, missed the button, clicked the wrong button, that kind of stuff. But still, you get a good population and a sample.
Yeah, our registration for the ambulance happens by the same person. So they physically see them come in, and yeah, they could maybe select the wrong mode, but it's usually, I mean, it's pretty accurate. The only time it gets not accurate is if, anytime you have something that needs to be done, there's a queue that develops. And if you have 10 ambulances that arrive exactly at the same time, you can't instantaneously register those 10 ambulances. So there might be, it might be a little bit far off, but again, it's a surrogate. It's as close as you can get without a stopwatch tester observer. So that's what we use. It's worked for us.
Yeah. And Elijah, before we get to AJ, I will tell you that I am working on something that's going to try to get it done by GPS, so that there's no human intervention. So I'm working on that. Should be ready about a month or two.
And Peter, just to piggyback, there's a lot of AI stuff going on now with wearing trackers.
Yes.
It's more on the dock running around within the ED, but that could potentially be used.
Well, and it's somebody brought it up in the chat where, hey, are we doing stuff with radio systems that timestamp things? Dr. Antipy, I think you're on the right track. We've got AVLs on most ambulances, and another thing to think about is application-based communications. So here at Emory Healthcare, we are working with LifeNet Care, which is sort of LifeNet getting on board with the app-based communication that we're probably all more familiar with: Pulsera, eBridge, Triage, those sorts of things. They all have geofencing capabilities. And for those really time-sensitive cases that are coming into Baystate Medical Center for strokes or STEMIs or traumas, those arrival times are all automatically time-stamped as part of that case when they pull into the parking lot. And so, we have, for those really high acuity cases, that there is a geofence that is tracked. And then we have our data abstractors for the different service lines and for the different case types, compile that into what is a very, very accurate data set.
Right. Beautiful. All right. Well, great conversation. AJ, you work with a very large health system, and you're very EMS friendly, and we've known each other for a long time. Love to hear your comments, and thanks for joining.
Thank you very much. And definitely similar to what everyone's been talking about, it's all about that relationship and seeing how we can mitigate it. We've done some trials in some of the healthcare systems that I've been with. First, from the registration standpoint, get the patient into the system immediately and then direct to the bed. There's no reason we should be waiting. We should be doing pull to full, figuring out how we can get EMS back into service. So we've worked on a couple different projects, both from the registration standpoint and then from the inpatient nursing standpoint, working with EVS, working with nursing services, working with inpatient transport, get those rooms cleared, find those extra beds, even working with facilities. Facilities knows where those beds are hidden. Go find them, put them in the hallways, have a nurse assigned to watching them for a little bit. And that way it does help decompress the entire facility, which then in return helps the emergency department not have those borders. It's difficult, and similar to, as Elijah was saying as well, we're lucky here in Palm Beach County. We get a lot of information from the fire rescue agencies, and we get those calls from the EMS captains or chiefs at times, letting us know, hey, what's going on? But it also goes two ways. We let them know as well, hey, here's what's going on, just a heads up, this may be occurring, we may have a slight delay here, so that they're also aware, because we do want that two-way communication with all the agencies.
Yeah. This is just a great example of smart people going through the systems, using lean processes, Six Sigma, et cetera. See, Dr. Barkoudah has his MBA, his MPH. You got Dr. Gemme, who's clearly good at running big systems, Nate. And so I would hope that what you're doing, I wonder if you could package this up into, and I do want to mention, and maybe I'll bring Joseph Zalkin, why this timing was so perfect is that the NAEMSP, our organization, our EMS organization, now has a bill going through Congress called the Meds Bill. And they have 4 things that they're looking at, and one of them is wall time. So, Joseph, you want to come on and talk about where the organization is? I don't see Doug Kupas, our president, but please make some comments.
Yeah, this was introduced in the last couple of weeks as a bipartisan bill with a handful of items attached to it, including looking at compensation of medical directors with an investigation in that regard, access to drug shortage medication, and then also adding wall time reporting as a CMS mandate so that you're out of your bubble. It's all in the light. And I'm impressed by your panel, folks. I know some of them. This is certainly part of the workflow issues and having the conversation with EMS. If you bidirectionally can tell people it's busy here, and if your system is set with a triage person to say, go to hospital B instead of hospital A, based on capacity issues, that's great. But I do think you have to focus on things. I also mentioned in the chat, and I don't know, maybe Nate knows, a clearinghouse for best practices. I'm with people. You want to rip off and duplicate from somebody else of what they looked at in their workflow corrections.
That's why I would really impress upon Seth, Ebrahim, and Nate to use this opportunity to maybe help others. I'm not asking you to start your own company, but obviously this is coming hot and heavy, and you guys have clearly you have it figured out with dashboards, data, metrics that the upstairs is seeing too, which I thought was brilliant. The fact that you have someone who's from the hospital side, a hospitalist on your team, that I think says everything. And so I guess to sum it up, and then I'll let our speakers give the final word. This is not an EMS problem. EMS is kind of at the bottom rung of the ladder, and we're the ones kind of suffering, but it has nothing to do with EMS after all. And so just very privileged to have you all on. So we'll start with Ebrahim, go to Seth, and then finish with Nate. Give us your last words. Give us some words of encouragement. If people are on here listening who say, I have a hospital who's not working together with me, like what should be maybe the very next step for someone who's listening today to take?
So let me just start. Our aim is the same. We owe it to our patient to deliver the best care. We need to think outside the bubble. We're going to call it the Baystate experience. Take down your silo, build a system that's safe, because we need it. We do not need probably newer drugs. We need to know how to deliver care within these walls from the EMS all the way to the discharge. Dr. Jimmy.
Yeah, I mean, I think the key here is I see, Gordon, your comment here. I mean, it's really the collaboration. That's the key. Now, how do you actually get at that? I think it's whoever is your EMS leader gets, close with the ED chief or ED chair, that then gets close with whoever's controlling the levers upstairs, which is in my case, Barkoudah. So if you do that, that's where it all starts. You got to get in there, because if you're one-off saying something to different people, there's no coordinated effort, and you're going to fail because it is such a complex problem. So I think, if you're an EMS, because just like you're saying EMS doesn't control this, neither does the ED. I mean, we have a little bit more control, but that's sort of the mentality we took and pushed it to the hospitalist and pushed. So it's that collaboration piece, and then be as data-driven as you can. The cases, the metrics, and know your data, make sure it's validated, make sure it can be trusted, because as soon as you go to these leaders with data, they're going to poke every single hole they can try to poke into it. And if you don't know it inside and out, and you can't know for sure that it's trustable, then you've got to kind of circle back, collect your thoughts, and then go back at it. So that's my two pieces.
Well said. Well said. Nate, take us away.
Yes, sir. So map the process. Map the process. You're going to see your bottlenecks. It's going to tell you who you have engaged or who you haven't engaged, because you see the patient flow through the system. And when I say that, I don't even think start outside from the 911 call. Map the process all the way discharged to post-acute care or back to home. Map that entire journey. And then I'm going to say, yes, be data-driven, because it's really about the patient. It's not about any individual service line or department's fault. This is about the patient. What can we do together to improve this patient's care? And then to hit just a bit of what Gordon's saying, in my experience, don't focus on the exact number that's your average wall time. Focus on whether or not we have an opportunity to improve. And if we can get to the point of, yes, we have an opportunity to improve, the exact number, it's arguable. But we do clearly have an opportunity to do better here. So let's start there and then start the conversation and get to a trust relationship.
With that, we thank you, all three of you, for coming on. I could see the sign in the shingle, Barracuda Consultants coming up. With a name like Barracuda, I mean, you're coming after them. I love this. This is good. If you look at this, at the links, guys, if you scroll up, you'll see the link to Dr. Pepe's webinar. For those of you who don't know, Dr. Pepe's webinar is a link of about 60 to 70 medical directors from across the world, and he gathers everyone every week as well. So please join there. You have your CME for this week is listed. This will be on YouTube. We appreciate all you guys. Have a great weekend. Stay safe out there, and thanks for the collaboration. Have a great weekend.
Thanks,
Thank
Peter.
you. Thank you.
Thanks, Peter. Good,
Gentlemen, thank
good
you.
topic.
Thank you.
Thanks, Kim. Appreciate it.